Okay, so before we get going here, I just want to let you know what your homework is. So if you go into Canvas, and you go up here, under Additional Course Files, ECG Strips 1 through 45 PDF.
Wow.
I'm going to publish that for you guys. And that's your homework for the weekend.
Okay.
Yeah. So, yeah. What's that?
Thanks.
Yeah, it's only 45.
Oh, only? Oh.
I mean, that's like an hour, right? That's like an hour. You could sit down, relax. You could knock that out in about an hour. So, yeah.
An hour, it's like an hour.
Yeah. So it is. It's 45 different strips up there for you guys. So to give you a really nice, good, robust practice session, they're all rhythm strips. Since we've done a whole lot of 12-lead stuff, I wanted to go ahead and hit you with a whole bunch of rhythm strips over the weekend as well, just to kind of get you studying and thinking about that. We'll go over the answers Monday, so you'll have those as a study aid going into your final on Wednesday.
You say it's a mixture of 12 leads and...
This one's going to be all rhythm strips. Yeah,
okay.
all rhythm strips.
I thought they were 12 leads.
No, all rhythm strips. Yeah.
All right.
5 is a lot of 12.
That's why I said it should take you about an hour or so, maybe 2 hours. All rhythm strips, easy, right? They they are very tough. I mean, they're not very. Some are easy, some are intermediate, some are really tough and nuanced. So it's a good mixture, but still,
So it's good for us to just all get together and do them again.
I guess I mean, just it's okay to work together. Just remember, at the end of the day, you're going to have to go in front of somebody you don't know,
Right.
and you won't have anyone helping you. So, I mean, it's okay to study together, but at the end of the day, if you don't understand it on your own, then that'd be a problem. But it certainly is helpful to run ideas off of people, though, and
Right. Yeah, no, not like one person doing it.
you can argue, and they can argue, and you end up learning a lot doing that.
Right.
Yeah,
That's right.
for sure. All right, let's move on. So that's your homework, ECG strips 1 through 45, and print it off at the computer lab. They'll make them very happy, but print it off anyway. They'll give you some ugly looks, but that's okay. Right? That's okay.
There's a lady that scolded, one of the workers scolded, like the manager is yelling at some girl because she printed off more than 10 pages or something.
Well,
You're
there's-
only allowed 10 pages a day, or I don't know. She
No,
was
it's not.
just-
No, I've never heard of that. Just go.
Yeah.
No,
This was over at DCC.
They have to be
making
double.
this,
They have to be
but I was like,
double-sided, right? If it's more than so many pages, that automatically
Right.
makes it double-sided. But yeah, there's no. Yeah, print that stuff off. Make them happy. I mean,
pay for it anyway.
it's part of your tuition, right? I mean, that's the way I would look at it. It's like, it's part of my tuition, whatever. You have a job. You have a job, because I'm here printing stuff in your computer lab. Don't. But anyway, I don't. I tend not to concern myself with some of the nuanced concepts of running a college when it comes to paying for paper and whatnot. Whatever. It's okay. So we had finished talking about DigEffect, and so what we're going to do now is we're going to move on talking about other concepts that can mimic STEMI. And the next one I want to talk about is this concept of hypothermia. Hypothermia can cause some characteristic ECG changes as well. And just to make sure we're all on the same page, we'll just go over some of the background information of hypothermia, and that is to say, what is considered what. In hypothermia, we divide into 3 different categories: mild, moderate, and severe. And we tend to say that mild hypothermia is 32 to 35 degrees Celsius. You tend not to see real significant ECG changes in mild hypothermia. Okay. Once we go below 32 degrees Celsius, so 29 to 32 degrees Celsius is considered moderate hypothermia. This is when we start having some of those classic problems associated with hypothermia, the bradycardia, The shivering tends to go away as we transition into moderate. The mental status becomes altered. You have hemodynamic changes. You have changes with your clotting cascade. Your clotting factors begin to denature and not work as effectively. And then finally, severe hypothermia is considered anything less than 29 degrees Celsius. So, what do we commonly see on the ECG? Well, would you imagine that we see sinus bradycardia? Hey, how about that? AV blocks, does that surprise anybody? What about shivering artifact? Does that surprise anybody? No, but perhaps something that you're not as familiar with is something known as the presence of J waves. These are also known as Osborn waves. And these become more pronounced as the patient becomes more hypothermic. All right? So these can mimic STEMI, and as you start seeing these changes, your patient is going to be at risk for other dysrhythmias, specifically VTAC and ventricular fibrillation, other things like AFib, okay? And when they're hypothermic, these rhythms tend to be very resistant to treatment. And in fact, our medications even recommended for somebody in severe hypothermia.
Medications?
Yeah, if somebody goes into VFib. What would you normally give somebody in VFib? Without a pulse, VTAC without a pulse. What medications would you normally give them? Say it again? Yeah, you normally give epinephrine, right? Why didn't you guys all say that in unison? Right? That's like standard. Everybody in cardiac arrest gets what? Epinephrine, what? 1 to 10,000, 1 milligram, IV push, Q 3 to 5 minutes. That should be something that you shouldn't even have to really think about it at this point. Yeah. But with that in mind, would we want to do that with somebody in severe hypothermia? Why not? Why not? What's going on there?
I mean, your metabolism's different than it would be at a normal temperature.
Yeah, you certainly have, your proteins are not working very well.
And it's not an issue with, your heart's normal ability to function. It's the cold
Well,
that's causing it.
Where is that epinephrine going when you give it? Is it? If my temperature is like 27 degrees Celsius,
It's not making it to.
where's it going? Where's that epinephrine going?
Staying wherever you put it.
Yeah, right? Because what do you have? You have massive amounts of shunting occurring, right? You have shunting, you have vasoconstriction. You don't have good circulation to your extremities, and that's more than likely where that epinephrine's going, right? Because that's where you started your IV. So you code somebody, right, and you give them 5, 10 milligrams of epinephrine over the course of your code, 30, 40, 50 minutes, and then you finally get them warmed up a little bit. What do you suppose is going to happen once they start warming up? You're going to have that after drop phenomenon, right? You're going to have all that epinephrine that you injected peripherally is going to get dumped into their central circulation, and all that epinephrine is going to go circulate to their heart, which is already irritable due to the underlying hypothermia. Doesn't seem like a recipe for success, does it? No. So, in general, patients with moderate to severe, particularly severe hypothermia, medications are contraindicated until you get them warmed up. Right, until you get their temperature solidly above 29, medications are not indicated. Okay, so what does this J wave or this Osborn wave look like? Well, let me show you what it looks like here. Move this guy up here. Here we go. All right, so it produces this really characteristic looking complex here where it almost looks like there's a T wave right on top of that there. You see that? But actually, your T wave is here. So you kind of almost have like this RSR prime looking kind of complex, kind of like rabbit ears. You'd be like, oh, that looks like a right bundle branch block, right? But do you see how this one here has a real sharp appearance to it, and then the second part of it kind of has that round appearance? You see that there, and then it's followed by, in this case, an inverted T wave. You see that? That's a classic, what we call J or Osborne wave. And this can be fairly subtle. So if we go over here, I have an example. Okay, so we're looking at V4 and V5. So we're looking at our anterior and lateral walls, these specific leads. And if you just look at that, right, what would you initially think might be going on here? If I go to my baseline, that looks like a STEMI, doesn't it? Does that not look like a STEMI? But what you have here is you actually, this right here, okay, is actually part of the J wave. Do you see that there as well? Right? Yeah. And this is somebody with moderate hypothermia here. Okay, so you're already starting to see these subtle changes, and you can see how you might mistake this for some other problem. And do we often check temperatures? Is that something you see done a lot out in the field? Should be done, right? Should be done on everybody, right? Because temperature, it should be done on everybody. It's a standard vital sign, right? Because you can have somebody who's hypothermic and you don't even know it, right? It's really easy to get hypothermic, right? If somebody has taken a medication, right? A lot of drugs can cause hypothermia. So you can go into somebody's home and they can be lethargic, or they can be having some chest pain, or they're not acting right. And you throw a 12 lead on them and you see this, and your initial thought is, oh, this is some kind of cardiac issue, right? And so you start treating them, and you have completely discounted the possibility that they may have some sort of temperature, some sort of thermoregulatory problem, right? And then you throw on diabetes, peripheral vascular disease, all kinds of medications, substance use and abuse, all of that kind of history, okay, can make your patient much more prone to hypothermia. And of course, trauma is a big one as well. So, yeah, don't let it fool you. Don't let it fool you. You guys okay with that? With J-waves or Osborne? Okay, cool. Well, look. Okay, so the next one I want to talk about, and it's a fairly common finding, and this is something known as left ventricular hypertrophy, or LVH. All right. And so what tends to happen is if you have increased pressure and workload on the left ventricle, over time, it will hypertrophy. And what is hypertrophy?
Bigger cells.
The cells become bigger or more numerous? Is it? It's more numerous, or is it bigger?
I thought it was bigger.
It's bigger.
More numerous.
Who just took pathophys?
Yeah, who's taking that?
Yeah, who just took that?
I just took it like a month ago.
Yeah. Right? Remember your cellular adaptations to stress, injury? Hypertrophy is enlarged cells. Hyperplasia is increased division, right? Increased number, right? Metaplasia is what?
Cancer.
Not necessarily cancer. Cancer cells tend to be metaplastic, but what does metaplasia mean?
Growing in a different location than it should.
That's metastasis, is spreading, but what is metaplasia?
Control growth.
No, it could be, but it could be associated with that. Metaplasia is when cells lose the specific function that they're supposed to do, right? They lose their specific function. Huh?
Oh, you mean they're...
Like, hey,
Yeah.
I'm a cell that's supposed to secrete some hormone. Oh, not anymore,
Right, okay.
right?
Isn't that's cancer?
That's not cancer. It's part of cancer, though. Cancerous cells are they undergo metaplasia, but they also undergo hyperplasia, right?
Right, there's more of them. And
Right, they
change.
begin to divide uncontrollably, they lose their specific function. Okay, so it's not just one concept with cancer, it's multiple things that happen there with cancer. Yeah. You guys okay with that?
Yeah.
All right, so
Hyperplasia was
they begin dividing.
get more.
Yeah, they begin dividing, right. But this is hypertrophy that we're talking about here. This is pretty common. And what do you suppose the most common cause of left ventricular hypertrophy is going to be? Yeah, it's up on there, but yeah, hypertension by far is the most common cause. Why? Because your left ventricle is having to work harder, right, to pump blood out. Your afterload is very high, and your left ventricle has to overcome that afterload to get blood out to the body. So we tend to see this is a very common finding in older people, right, or people that have had hypertension for many, many years. You can also see this with some of your valvular issues, specifically your aortic and your mitral valve, because those are valves that specifically interface with the left ventricle. And then there are certain cardiomyopathies, specifically hypertrophic cardiomyopathy, where you can get left ventricular hypertrophy. But by far the most common cause is hypertension, high blood pressure. Okay? You guys okay with that? And so what happens is, as that left ventricle enlarges, okay, you're going to have depolarization occurring. You're going to have more electricity moving through that area. Does that kind of make sense? And so what we see here is we have a few different ways we can identify it. I am going to show you the easiest way for you guys. Okay, it involves the least amount of variables. All right. And it's called the Scarboss Criteria. You don't have to remember that. But it is looking at the depth of the S wave in V1. Okay, so you find the S wave in V1. You count how many millimeters tall it is. Okay? And then you find the tallest R wave in V5 through V6. Okay, or V4 through V6 actually is what it should say, but there we go. All right. And if the sum is greater than 35 millimeters, left ventricular hypertrophy likely exists. So if we look at this ECG here, all right, I have taken the S wave, right? So here's the R wave, and then here is the S wave, right? You guys okay with that? You got your RS complex there?
And that's any one of them, right?
No, V1, right?
Yeah, only in V1.
Only in V1.
There's three of them there. You pick any one of them. It's the
Yeah.
other one that's the tallest, right?
Yeah, V4, 5, 6. Yeah, so V1. And so and you see how I counted it there, right? And I came up with 20 millimeters, all right? You guys okay with that? And then I went over here, 4, 5, and 6, and it looked like V4 was the tallest. Or rather V5. I don't know what I'm doing today. That said V5 and V6, right? Yeah, it should be V5 through V6. It should not be V4. We're looking at the lateral. So we went to V5 here, and I started down here, and then V5 went way up here. And then I counted how many boxes. Came up with 39 boxes, 39 millimeters. So 20 plus 39 gave me what? Gave me 59. Does that meet criteria for LVH?
What was it? Greater than
35.
Greater than 30.
Yeah. You guys okay with that? Okay. If you eyeball the 12 lead, when you eyeball the 12 lead, what you're going to see is you're going to see these, see how these R waves, or these R and these S waves here are kind of really tall and kind of blending into each other a little bit. You guys see that there? That just at a glance, is a dead giveaway that you're probably dealing with LVH. And then actually going in and counting them. But when you see them and they're really, really long like that, that's a lot of muscle tissue, additional muscle tissue, muscle mass that you're having to depolarize that causes them to be really long like that.
I was just gonna ask that,
So
was that on one of our
It was, yeah, but it was something we hadn't covered up to this
Right.
point. So.
So that was just my question, was that
That one with the really.
this
super-
represents an electrical, like, distance. That's why the
Yeah, you could look at it that way.
force is-
There's just more
'cause
mass.
it's not more voltage, right?
No, the voltage is well, yes, in the sense that there's more mass, and so there's more there are going to be more ions, and
Ions,
yeah.
okay, all right.
So yeah, in that sense, yeah, there is more of a potential there.
Okay, so that's why you're
Yeah.
getting the big.
Yeah, it's just there's more mass that needs to be depolarized, and that's how it's manifested by those really long
Okay,
RNS waves that occur.
thank you.
Yeah, no problem. Yeah, so when you see ECGs like that, where they blend into each other, you're like, it looks like our LVH. Now remember, left bundle branch block kind of throws a wrench into that, though, right? Now we don't have a huge block going on here. These actually are a little wide, but this is very clearly LVH going on here. And if you're not careful, you can see how it does mimic, ST segment elevation, particularly on the left side of the heart in your precordial leads. It can kind of manifest as some ST elevation.
So if we get this, I mean, what would be the determining factor on, would we just say, oh, hey, we've got this, we're dealing with LVH,
Uh-huh.
we're not running it as a STEMI, or is this something that where's that line where we start going towards a STEMI, or we just stay on the LVH?
Yeah, if you have LVH like this, this is clearly not a STEMI,
Okay.
right? They're just clearly, it's clearly LVH. The elevation's pretty subtle, right? It can be accounted for by the presence of LVH. Now, ultimately, the ultimate diagnosis actually requires echocardiography, where we go in, we take a look at the heart, look at the ventricle itself, because LVH may not present with any specific ECG finding. You may have a normal sinus rhythm and still have LVH. So it doesn't always present like this, but when it does present like this, it can confound the diagnosis of a STEMI. So again, that's where history and physical exam is so important when it comes to these acute coronary syndromes. But you wouldn't really have enough evidence to do like a cath lab activation based on this. You could certainly say, hey, look, they have signs and symptoms that suggest STEMI, but the 12 lead is just, I've got some LVH, but it's not screaming STEMI. Does that kind of make sense there? Cool. All right, you guys okay with that? So far, so good. Okay, let's move on to yet another mimic, and this one is a potential showstopper. If you do not identify this could be a life-threatening showstopper, and that is hyperkalemia. Okay, hyperkalemia. Potassium in general, any imbalance in your potassium tends to be associated with cardiac conduction anomalies. So I just kind of remember potassium affects the heart, sodium tends to affect the brain. When you have sodium anomalies, hyper and hyponatremia, that tends to present with things like seizures, cerebral edema, altered mental status. But hyperkalemia and hypokalemia to some extent impact the heart very significantly. So what do we see with hyperkalemia? Well, first of all, what's your normal potassium level? This is something you guys should.
3.5 to 5.
Good, so 3.5 to 5. Some people will go up to 5.5, but 3.5 to 5 milliequivalents per liter is your normal potassium. How about sodium? Let's just throw that in there.
35 to 145.
Good. 135 to 145 milliequivalents per liter is your normal sodium. Okay. So once you get above 5.5, whatever threshold you want to use, once you get above that, then you're dealing with hyperkalemia. And the first thing that we see are tall peaked T waves begin to develop. Okay? So your T waves get tall, and your P to R interval becomes prolonged. Okay?
Just over 0.2?
Yeah. So it not only that, but the P waves get pushed down. So I imagine the P waves pushed down and the T waves pushed up.
So they're actually inverted?
Yeah.
Okay.
When they don't get inverted, the P waves don't get inverted, they get pushed, they get squished.
They get squished.
They get flattened down. They get flattened down, and the P to R interval increases, whereas the T waves increase, right? They get pushed up. They become tent-like. They look like tents, all right? And then as the hyperkalemia becomes worse, once you get above about 6, 7 milliequivalents per liter, you lose your P waves altogether. All right, you have a loss of P waves, okay, and you get a very classic ST elevation looking thing. It looks very much like a STEMI, okay. The QRS gets widened out, okay, you're like, oh, boy, that looks like a bundle branch block. And then you start getting ectopy, PVCs, PACs, PJCs, as the heart becomes more and more irritable. And then finally, once you get above about 8 milliequivalents per liter, the T wave pretty much blends into the QRS complex here and produces what's known as a sine pattern. And that's basically, you know, based on a sine wave. If you graph a sine wave out, it becomes more and more sine wave-like. All right? And, huh?
A sign?
Sine. Like remember in high school when you had to graph a sine function?
Like a normal wave?
Yeah,
Like
yeah.
a sine wave?
Sine wave, yeah. It becomes more and more like a sine wave and less like a PQRST complex. So at this point, there are no P waves, yeah. And then this, of course, leads to cardiac arrest, all right? And it is a very difficult to treat. It's a refractory, okay? If you defibrillate them, they tend not to respond. They don't respond to medication, CPR. One thing to notice, though, hyperkalemia may not cause ECG changes at all. So you can have somebody who's profoundly hyperkalemic, and their ECG may not look particularly bad. Okay, like sometimes up to half of patients with severe hyperkalemia may not present this way. But a lot of patients do. This is the classic presentation of hyperkalemia. Tall peak T waves. But what else presents with tall peak T waves? Benign early repolarization does, right? So how do you differentiate this from benign early repolarization? History, right? History, yeah.
So what would their history be?
Talk about that.
Awesome.
Before we do that, let me just show you some examples. So here we go. So here's an example of mild to moderate hyperkalemia. So we're, 6.5, somewhere in there. So what do you see?
Yeah, P waves are like
Right.
gone.
So you don't really have much in the way of a P wave,
T
right?
waves are real tall.
And you've got these really tall tented T waves, and they're generally symmetrical appearing, right? They have a fairly symmetrical appearance to them, right? And they kind of look like tall tents. You guys okay with that? And then what's going to happen is we're going to get more and more severe. So this is somebody with, I think they're like 8.5 or 9 here. And what do you notice?
Does it look kind of like a sine wave?
Yeah, it's looking more and more like a sine pattern. No P waves. The QRS is basically blended into the T wave. And you're basically left, I mean, if you were to look at that, you'd go, oh, that kind of looks like an accelerated idioventricular rhythm, right? Would you guys agree? Kind of looks like that. An accelerated idioventricular rhythm. And maybe if it got faster, it would look like VTAC. You guys okay with that? Yeah, so that's very kind of a classic hyperkalemia. So what are our major causes of hyperkalemia? Well, we'll just review them real quickly. Renal failure is a big one. One of the biggest down here, renal failure. It's very common in patients who are on dialysis. They get sick or they become non-compliant and they skip dialysis. And this is a classic test question. You go and you're assessing somebody who has diabetes and they're on dialysis, they have chronic renal failure, they've missed a week of it. Here's a 12 lead. What's going on with this patient? It's just a classic test question that comes up. Hyperkalemia, tall PT waves. Yeah, that's just even though we don't see it a lot in a lot of patients, it's still a very classic thing that people are asked about. But that is a big cause. Other causes, crush injuries. Why do you think crush injuries would be a cause for hyperkalemia?
Because it
Potassium
all
leaks
of
out.
There you go. You have massive cell death. And where is most of the potassium in the body stored?
the cells.
Intracellularly. Good. Some drugs, like succinylcholine. You guys in pharmacology, have you talked about succinylcholine yet? Not yet. Okay, it's a neuromuscular blocker. How does it work, those of you that have taken pharm? How does it work?
Does it block the nerve receptors?
Mm-mm.
Oh, this is the one that, it's,
Because there are two categories of neuromuscular blockers, right? They're your depolarizing and your non-depolarizing neuromuscular blockers. How does SUX work?
it's depolarized.
Yeah, it causes the muscle cells to depolarize. And in certain patients that have problems with potassium channels, okay, if they have some genetic issues, that can cause a massive shift of potassium out. People with who have had a burn, or chronic burn patients, people who have had spinal cord injuries, people who have muscular dystrophy, those kinds of things are going to be very prone to developing life-threatening hyperkalemia if they receive SUX. So, because it causes depolarization and they have very upregulated potassium channels. Okay, salt substitutes, right? So a lot of people that don't want sodium in their diet may do like a salt substitute, and what do they substitute it with? Potassium instead of sodium, right? So yeah, burns. Why would burns? Same thing as crush injuries. Something called tumor lysis syndrome. This is something we see in patients that have cancer, and we start them on chemotherapy, and their tumors start going bye-bye very rapidly. So have lots of destruction, lots of lysis, how about that, of tumors. That among other things, can cause hyperkalemia. Potassium supplements. Why would somebody be on a potassium supplement? What kind of patients would you expect to be on potassium supplements?
I think cardiac patients are on potassium.
Why, though? What's going on?
I've heard it for hypokalemia.
And who is at risk for hypokalemia?
Pregnant people.
Maybe.
The only reason I know my wife.
Maybe. What about people with hypertension, or congestive heart failure? What's a common drug? If we look at their drug list, what is a very common drug that we would see them on? What do you guys think?
Blood pressure medication.
Yeah. What type of medications specifically?
Potassium in it.
Like ACE inhibitors.
Okay, possibly an ACE inhibitor. Okay. What else? maybe beta blockers. What else do we put people with hypertension and or congestive heart failure on? Diuretics, right? Right? Diuretics. Specifically, and I think you mentioned loop diuretics. Where do loop diuretics work? Loop of Henle, right? What do they do? What do they do at the loop of Henle?
Cause reabsorption or non-secretion of ions. Filtration. They don't-
You're on the right track. You're on the right track.
They cause less reabsorption.
So they make you get rid of, excrete sodium ions, right?
Yes.
So when you excrete sodium ions, that is, sodium ions leave the body, what follows sodium? Water, right? That's how they have their diuretic action. But the way that that works is there is a sodium-potassium pump there, an exchanger, right? So what happens is you also are getting rid of potassium at the same time you're getting rid of sodium. Okay? That's just a side effect of that. And so you pee off potassium as well as sodium, right? And so loop diuretics are also known as non-potassium sparing diuretics. Yes, right. So anybody who's on a loop diuretic, what's the most common one that we see given? Lasix. Good. Lasix, or what is the generic for Lasix? Should be capital. Yeah, furosemide. Good, good. All right. Very cool. And then what's rhabdo? Rhabdomyolysis. You heard of that? It's similar. It's somewhat similar to the concept of a crush injury. It's where you have lots of breakdown of muscle tissue. Specifically, rhabdomyolysis is a lysis, a rupture, a breakdown of muscle tissue. And we see this in we can see this in burns. We see this in crush injuries.
What about just starvation?
Starvation, heat injuries, very common in heat stroke. And I'm not talking about I passed out at the parade and I had heat stroke. No, you didn't. You didn't have heat stroke. You guys know, okay, heat stroke is the life-threatening manifestation of that. Like somebody tried to get in from Mexico and they wandered around for a couple days. They got dehydrated and you found them down with a very high core temperature and, their very altered mental status, etc. Rhabdo is pretty common in heat stroke as well. And again, why? Because you have all this muscle tissue being killed and you have a lot of potassium being released. Okay, you guys good with that? So how do we treat hyperkalemia? I know that the focus of this class isn't necessarily on treatment as much as identification. Yes. So it's a 3-step process. The first step, the most important one, is to stabilize the cell membrane. Okay, and that is done with calcium. It can be calcium gluconate or calcium chloride. Either will work. But you give the calcium, slow IV, and that buys you time. That stabilizes the cell membrane. It buys you 45 minutes to an hour right in there. Okay, it buys you time to start other treatments. But that is the life-saving initial treatment. Okay? It's kind of like, what's the life-saving treatment for a tension pneumothorax? Needle decompression, right?
Yeah.
That buys you time.
But it doesn't fix the problem.
Right, it doesn't fix the problem, but it buys you time. It buys you time to do a chest tube and do other things. That's kind of a similar concept here. Stabilize the cell membrane. Step 2 is to push potassium back into the cells. Okay, and this can be done with several different modalities. This can be done by giving insulin and dextrose 50%. Insulin is very good at shifting potassium into cells. All right, so we'll give them like a bolus of 10 units of regular insulin and then followed up with 25 grams of D50. High-dose albuterol okay? Not 2.5 milligrams, but like 20 milligrams of albuterol. So you'll put them on a continuous nebulizer, high-dose albuterol. And in fact, you guys are doing drug cards in pharm, right? You've already talked about albuterol? Well, you guys should all know about albuterol, most of your intermediates, right? If you don't know about it, right? This is a common side effect of albuterol, is hypokalemia. You got to give a lot of it, of course, but hey. And sodium bicarbonate as well. Okay, this is one of the instances where sodium bicarbonate may be helpful. So you give the calcium, and then you start with these other therapies, the insulin, the D50, the albuterol, the sodium bicarb. And then finally, we need to get rid of the potassium from the body. What's going to be the primary way of doing that? Dialysis, dialyze them, yeah. Now, there are some other treatments. There are what we call potassium exchange resins. These work in the gut. So you give it orally. It's generally like a liquid. You give it orally, and the way it works is it kind of holds sodium in the gut, and then, of course, kind of like with diuretics, right? You're pulling sodium and potassium. And when you do that, it pulls water into the gut, and then it acts kind of as a stool softener. That's actually what this medication is designed to do, is to soften stool. It's something known as K-oxalate. Have you guys ever heard of that? K-oxalate, or sodium polystyrene. Yeah, it'll give you lots of diarrhea, lots of poopy diarrhea. Problem is, it really isn't all that effective. If you have somebody who has life-threatening hyperkalemia, the K-oxalate, they need dialyze. That's really what they need, not K-oxalate. You can give that at some point, but yeah, dialysis, a big thing there. So can we do some of these things as paramedics? Yes. We can do a heck of a lot of these, right? We can give the calcium. We may or may not be able to give insulin, but we can certainly do calcium. We can certainly do albuterol. We can certainly do sodium bicarbonate. Okay, so we can actually make a very profound impact with life-threatening.
Would you do albuterol and the sodium bicarbonate?
Huh?
Would you do albuterol?
Sure. Oh yeah, yeah. If you see this, you're seeing this on your patient, and they have a significant history. Oh yeah, yeah, definitely. You definitely want to be aggressive. Yeah, for sure. All right, does that make sense, guys? All right. Everybody's okay? You guys? All right. Well, let's move. Yeah, Brugada Syndrome. There we go. Yeah, Brugada Syndrome. I'm not going to go into a whole lot of detail because this is a fairly rare thing, but what it is it's a genetic disorder. It's a genetic disorder, and it involves the sodium channels in myocardial cells. Okay, they're altered. And so what it does is it presents as kind of a widening of the QRS and a very, very characteristic looking ST depression there. And that's known as the Brugada sign. So if somebody has Brugada syndrome, they're not having a STEMI. That's just a normal, that is what their QRST complex will normally look like. May not see that as an appropriate activation. Does that make sense? That may just because there's a left bundle branch block may not be enough information.
So would you just tell them
Well, we're going to tell them. We're going to talk about. Yeah, we're going to talk about what we can do. Okay. So what we're going to have to do is we're going to have to look at the ECG in a little more detail. Okay, and this is something known as Scarboss Criteria. All right, Scarboss Criteria, yes. And tell you what, you want somebody to talk about Scarboss Criteria all day long. What's his name? He's with the fire department. Does all the reptiles. And,
Mike Daniels?
Daniels, yes, he is a Scarboss freak.
I'll have to mess with him.
Oh yeah, he is all over this stuff. Discordance, concordance, and yeah, he just loves it. There are actually several dimensions to this. I'm going to talk about the easiest way of looking at this. Okay, it involves 3 different things here. Okay, number 1, do we have concordant ST elevation greater than 1 millimeter? What does that mean? Concordant elevation is elevation that deflects or moves in the same direction as the QRS complex. So you guys can see that that looks like a bundle branch block there, right? A wide QRS. And I have some elevation, and that elevation is moving in the same direction. Okay? So do we see that? Do we see concordant ST elevation greater than 1 millimeter? Okay? When we look at it, do we see concordant ST depression greater than 1 millimeter in V1, V2, or V3? Okay? So I look at my V leads, V1 through V3, and I look, and do I see? And so do you see here how, for the most part, the QRS is going down there, and the ST depression is going down, and it's very significant. Okay? And then the final thing that we look at is what's called discordant ST elevation. And discordant ST elevation is ST elevation that moves in the opposite direction as the QRS. So my QRS complex is right here, and then you can see the elevation is right here. It's deflecting in the opposite direction of the QRS complex. A pretty common thing that we see in bundle branch blocks, specifically left bundle branch block. Here in just a few minutes, I'm going to actually take you to this article. I want you to read this article. It's actually not a bad read. It's not very long, but it is a very good review of Scarboss criteria and how effective it is at identifying a potential STEMI. Unfortunately, Scarboss criteria is not without its pitfalls. And there have been some modifications that have been done. Some people use these modifications, and they're different points. They'll assign different points to different criterions, and then they'll say, well, if it's greater than 5 points or this or that, that's... I'm not going to have you guys actually analyze bundle branch blocks with using Scarboss criteria because there's so much variability there. But I do want you to at least be aware of it and understand that it is a tool that you can use when you have a bundle branch block and you're really concerned. Okay? I think it's very easy for us to say, well, who cares, right? I'm going to treat it as a STEMI, right? The problem is, it's nice to have a tool that you can use to justify what happens in the hospital, right? Because if you truly believe that your patient's having a STEMI, you're very concerned about them, you want to get them into the cath lab, you've got to convince somebody, right? You've got to get somebody on your side that can activate that cath lab. Otherwise, it doesn't matter if you treated it, right? You gave the nitro, you gave the aspirin. Well, I made the right call. If you dump that patient off in the ER and then that patient sits in the ER for an hour or two while they do this, that, and the other thing, there may very well be a significant delay, right? So if you understand this tool and you use it and go, hey, this is a positive Scarboss criteria for STEMI, right? That allows you, that gives you some leverage when you're talking to physicians, right? Specifically, because it's the ER physician that's going to make that call, right? And if you can talk to them intelligently about this, and they realize, oh wow, this a paramedic who understands this in a lot of detail, right? And you articulate this to them, you might be able to get them to activate the cath lab, get that patient into the cath lab where they need to go. Does that kind of make sense? How that little bit of extra knowledge can really help you facilitate good patient care. And unfortunately, you can't really rely on the nurses to make these calls, because the nurses are not in general, not as interested in reading into ECGs. I don't know if you guys have seen that or not, but they've got a whole lot. They've got a lot of other things that they're dealing with. So, for the most part, ER nurse in general, you say Scarboss Criteria. What is that? So this is really talking to the physician and getting them on your side. But we'll look at that study here in a few minutes. Let me get through the rest of the major mimics, which we've almost done. I think we've got one more to talk about. Let me go back here, and we'll zoom in on this. This is a 12 lead with that classic Brugada sign. Do you see that there? Very classic Brugada sign there in V2, a little bit in V1 as well. And so if you look at it, you're like, oh boy, that looks like ST elevation, but it has that real characteristic kind of, you look at it here, and then it kind of has that characteristic double slope feature to it there. And this is unfortunately one of 3 different manifestations of Brugada syndrome. It can manifest in 3, they're actually what they call 3 types. It's not that there are 3 literal types of Brugada syndrome. Brugada syndrome is Brugada syndrome, but there are 3 ECG manifestations. This is one. I believe this is the type 1 manifestation. And again, like I said, it's not like the most common thing in the world, but I did want to mention it. And if you want...
How early is this diagnosed? Like, is someone going to know it?
Yeah.
Do they have it?
Yeah, with this, to make a definitive diagnosis, they actually have to be worked up. So this is not something that you're necessarily going to find out in the field on somebody. And what tends to happen is you tend to have a family where people die suddenly. They have like sudden death, and then they start working up people, and they do autopsies, and they realize, oh, I have a genetic defect of the gene that codes for these sodium channels. Or what can happen is as a kid or a young adult, these patients may have a syncopal episode. They'll end up in the hospital. Their EKG will look abnormal. They'll work them up, and they'll find out, oh, they have Brugada syndrome.
So the chances are they probably don't know they have it.
Yeah. Either they don't know, or they already have been diagnosed with it. They do know, and they'll tell you, hey, I have Brugada syndrome. If they tell you they have Brugada syndrome, and you run a 12 lead and you see that elevation, you should really going, okay, this is what I would expect to see with somebody that has Brugada syndrome. But these patients are definitely going to be at higher risk for sudden death due to the impaired sodium channels. So I just wanted to mention that.
Has that ever been linked to like SIDS? Have you ever heard any?
Not that I'm aware of. Yeah.
Just wondering.
Yeah, because SIDS is generally, when they do a post-mortem on SIDS, the findings are not real significant. Yeah, because if they found like something like this, a polymorphism, then they wouldn't call it SIDS. They would call it, Wolff Parkinson's or whatever the problem is. But SIDS, the autopsy tends to be not really a whole lot of solid stuff going on.
Chris's example you give, are we going to see that in, V1, V2, a little bit in V3, but then
this
the rest look normal? Are those ones that are going to be classic?
Yeah, it's pretty classic, and some of them, like if you look at AVL, it's a little weird looking, it's a little wide looking there, but yeah, like if you were just to look at lead 2, you wouldn't see much.
Yeah. Well,
You wouldn't really be impressed.
Also, I don't know, is this something that's going to have characteristically, like, a lot of the leads look slightly depressed, like
Some of them.
lower than a box.
Yeah,
so
you do have some depression.
Is that
Even in like lead 2, you have a little depression there. Yeah.
a classic sign of, you're
Yes.
going to find that? Okay.
Yeah, this kind of pattern of this characteristic elevation, and then you're going to have some depression, and it's just going to look. And this can be tricky because you could code somebody. Let's say you go and you run a code on somebody, and they're down and they're in VFib. You start CPR, you defibrillate them, and then you go back into sinus rhythm. Well, what are you going to do? Yeah, you're gonna run a 12 lead, and then that pops out. What's the first thing that's probably gonna pop into your mind?
Ischemia.
Right, you're gonna think, oh, they're having a STEMI, and it's the STEMI that caused the VFib, and you know what? That is generally what we see, right? You know what like half of all deaths are due to deaths with STEMI are due to life-threatening dysrhythmia. So it'd be really easy if you didn't take a little extra time to look at it and consider other possibilities. It'd be really easy to print that off and go, oh, having a STEMI, that's what caused it, instead of, oh, wait a minute, sudden cardiac death, this characteristic elevation, it could be Brugada Syndrome. Maybe I'm going to hold off on drugs that affect sodium channels and affect the QRS, like sodium channel blockers, like procainamide, those kinds of things. Maybe in treating that patient, I'm going to hold off on that kind of stuff because I'm suspecting Brugada syndrome there. So that would be an example where there may be some clinical crossover there, where it's not just an academic exercise. But that kind of makes sense? Okay. Whew. Finally through this stuff. Well, the mimics. Unfortunately, there are many, many more. And I just don't have enough time to talk about all of the possibilities, but at least we've covered some of the major ones. Bundle branch blocks, pericarditis, digoxin, hyperkalemia. These are some major ones. These are common, big baddies. Some are very common and not bad at all, like benign early repolarization. So hopefully at this point, you at least have some tools, or you understand that there are some tools that you can use. We're looking at the 12 lead and getting some more nuanced information. You guys okay with things so far? All right, take a break.